while they prepare the case, I apologize for my deep voice because of flu, but I think it goes in theme with the cardiogenic shock talk, and it gives 8 minutes is good. And no one can beat a remarkable result like the previous case, which is always in pediatric. It's always remarkable how they can always bounce back. So I'd like to thank the organizing committee for inviting me to talk about a case that I have, but actually it goes in theme and in line with the theme of this session. Can we reverse cardiogenic shock? Hopefully we can, but in my case can we prevent it and can we anticipate it at least? As mentioned, I'm an assistant professor, interventional cardiologist at King Saud University. My case is a 66-year-old gentleman who is known coronary artery disease with a very remote PCI in 21, had CVA and TIA, but unremarkable neurological deficit. Remarkably, he doesn't have any risk factor of diabetes, hypertension, or dyslipidemia. And I think what plays a major role in his coronary artery disease is the heavy smoking habit that he has. Also, which led him to be a severe COPD, one step closer from home oxygen. He was also a survivor of cancer, stage 3. He underwent chemo and radiotherapy and in remission from 2016. So he was admitted at another facility with acute decompensated heart failure and a case of non-STEMI, CCS class 3 and NYHA class 3, and the echo back then, which because he didn't have any follow-up, showed presumably new low EF of 20% with severely dilated left ventricle and severe MR. I'm going to go quickly over the angiogram just to show the finding of tortuous left main, totally occluded LAD, or severely calcified LAD with some competitive flow, and a CTO to the right. Can appreciate how big is the heart, and also the collateral to the right side. Very heavy calcified LAD would make me think that it's not possible to do it without the help of plaque modification, namely rotablation. And this is a beautiful angle showing the amount of calcium in the LAD and how difficult is this case to begin with. And as I mentioned, the RCA is totally occluded at the mid-segment, filled by collateral from the left system. This is an LV-gram. It's one of the rare instances that the LV-gram is done. It shows that is barely moving heart in cardiogenic shock. Remarkably, wasn't in acute cardiogenic shock, but he is definitely in chronic state of shock. So he was sent back to the CCU for further management. He was managed medically because that facility did not have the high-end staff or the support, and discharged home remarkably after an extensive hospitalization in stable condition. However, despite goal-directed medical therapy for heart failure, the patient clinical status got severely worse, and he went back to an emergency. And the joint decision with his primary cardiologist was to go with the option of revascularization, albeit very high risk. And one of his workup was done to show the viability of his myocardium, was cardiac MRI that confirmed a severely dilated LV with severe LV dysfunction, a viable anterior wall and anterior apical, but distal fibrosis of the anterior wall, and a non-viable inferior wall with moderate mitral insufficiency. So that would change our strategy for this patient, at least to invest in the LAD and not consider the CTO intervention of the RCA. Well, as it is a habit, and it's a good culture to build in your hospital, to have a multidisciplinary round, to discuss these type of cases, because the outcome is definitely poor. The patient was deemed non-surgical based on many interventions. This is just before when CHIP was a very hot thing in the 2016, where nobody knew what's CHIP, and now we all know what's CHIP, and we are trying to advocate for CHIP as a category of intervention that wasn't feasible for some patients. And this is some of the criteria for how to classify, because it's also objective. what is complex for you may be maybe not complex for the others. So always refer for high volume center. They can do maybe more for the patient. We can see that his syntax score was 35, extremely high. Syntax 2 score showing a very high mortality at 78 for the PCI and 62 for cabbage. Recommended cabbage, obviously, and STS and Euroscore 2 indicate that this patient is at extremely high risk. In many, many centers, they would avoid touching this patient and just give him the option of medical therapy alone. And he did show a recent failure. So this is, I will not go through the available devices because it was mentioned by my previous colleagues, but mainly we have intra-aortic balloon pump, we have tandem hearts, and we do have commonly used in our cath lab an Impella that is very useful and it's very helpful. And I believe that it's, although some initially they did have some negative studies for the Impella, I think it's a valuable device that will help cases, and indeed it did help my patient. And most recent trials from the New England Journal of Medicine, published from ACC 24, showed at least a positive trend for the Impella usage for cardiogenic shock in anterior STEMI patients. I'm going to go skip the ECMO. Also, it's a good option if you do not have the Impella because it's extremely expensive. So going back to the patient, so the strategy and my plan was to consciously sedate the patient, ultrasound-guided femoral puncture, perclose the axis, and implant the Impella CP, and to do my intervention via right radial. And initial plan was to do the rotablation escalation of 1.25 and 1.5 burrs, and to remove, my intention to remove the Impella at the end of the procedure if the patient is doing well. So with a micropuncture, showing a good access and a good passway to the Impella. Not to bore you with it, but this is exactly when we look at it, we know that a complication will happen. So just wiring that lesion actually caused the patient to decompensate. We did have implant the Impella up front to have the support needed, and just show you, we use the echo guidance to place it accurately to have the best result of the ECMO, the Impella. And the moment, this was the initial Impella waveform, pulsatile, nicely, good blood pressure of 120 with a touch of Levofed. The moment I wired that LED with a whisper, he crashed. I mean, at least his waveform, where the patient actually was talking and chatting. It wasn't actually at all. So that gives me at least the impression of how valuable is this device, because it was maintaining a good flow to his brain to be able to talk. So given that crash, we decided that only the wire caused that decompensation. We would go with rotablation with 1.5, and the patient was completely dependent on Impella during the rotablation with volume replacement. And can we just use 2 minutes, please, just to show the final results? Because what happened to the patient is, as I mentioned, was talking during the procedure with no issues. Just 1 minute or two. Very good, thank you. So I'm going to skip to the end to show the result. We ended up with stenting the LED, hoping for an improvement. And then we implanted an osteal LED stent that was both dilated nicely with an NC balloon, all confirmed with IVUS that is well opposed with minimal protrusion into the left main. I'll have to show the last result with, of course, the distal LED wasn't touched because we know that it's fibrosed myocardium. So his clinical status actually was better at the end of the procedure. So we took the Impella out, admitted to the CCU, discharged home remarkably after a couple of days, and the 30-day follow-up showed significant improvement of his symptoms. And this is true real-life case where we see the patients to return to his life and return back to normal life and even working life. So my conclusion is that this is a way of revascularization that was deemed not possible for certain patients, but nowadays with these devices, we have the luxury of using it. hemodynamic support is truly indicated for these cases, because I don't think this case could have been done successfully without the support of Mbella. The most important thing is to have a team involved, because you need the cardiac surgeon help and assistance in case that any of these patients turn sour. Thank you so much.